start off by presenting on it's the annual report for 2021, and there's a list of the colleagues who contributed to the report itself, and you're very welcome. So this is the 10th report of the National Clinical Audit, and just wanted to mention on the right hand side a couple of highlights in the document. Every year we have an invited commentary, and this year it's on the exploring the complexity of stillbirth prevention and looking at insights from the relevant study on risk factors and implications for policy and practice. And this was written by our colleague Tamara Escanuela Sanchez, who's a postdoctoral researcher in NPEC and the Pregnancy Loss Research Group. So I recommend that you read the invited commentary from some interesting perspectives in terms of prevention of and change of behaviour for women going into pregnancy. And also we're very grateful to Professor Liz Draper, who from the University of Leicester, who reviewed the report in advance and gave feedback and comments so that we were able to improve the report before finalising it. So over the course of 2021, there were 357 perinatal deaths that were reported from across the 19 Irish maternity units from the 60,800 or so births that occurred that year. And these are ones that we provide most of our findings in the report are based on those deaths that reach at least 500 grams birth weight or at least 24 weeks of gestation. Each year, consistently, 2/3 of the perinatal deaths are stillbirths, and that was the case again this year with 200 for 2021, 238 stillbirths, 119 early neonatal deaths. We do also provide in the report short sections on an additional 40 late neonatal deaths, those babies that were live born but died in the second, third, or fourth week of life, and also 47 early neonatal deaths that are below 500 grams birth weight and born before 24 weeks of gestation. So this is your typical example of a busy slide where you can see lots of detail in terms of going back 10 years, looking at the number of births, the number of stillbirths, early neonatal deaths, perinatal deaths, and then corrected perinatal deaths where we exclude deaths due to major congenital anomaly. And then we calculate the rate each year per 1,000 births. So you can see over the period of time, approximately 4 per 1,000 babies are stillborn each year, approximately 2 per 1,000 early neonatal deaths. And then obviously together that gives us a rate of 6 approximately per 1,000 births for perinatal deaths. When corrected then, excluding those deaths due to major congenital anomaly, you can see it reduces to just under 4. In the table then we do a comparison of the recent year, the 2021, compared to the last 2 years, just from the point of view of we see fluctuations from year to year, but sometimes there's a significant drop or a significant increase. Those figures there are indicating that there was a lower rate in 2021, but only by a few percent and within what you'd expect as a fluctuation from year to year. So then looking at that trend over time, and again, this is the criteria that's been used as having a gestational age of 24 weeks at least, or a birth weight of 500 grams or more. And we can see that the total perinatal mortality rate, some fluctuations, but relatively stable over those 10 years. In the grey then we have the stillbirth rate, and in the green the neonatal death rate. And the dashed curves there are the corrected perinatal mortality rate, which is always very similar to stillbirth rate, almost somewhat coincidentally. We do a little bit of comparison with international countries. It's quite difficult because there's different criteria applied. So for the purposes of this presentation, we've included a comparison with our UK colleagues and the component countries of the UK. Now, just mentioning in the middle there, you can see it mentions the criteria of gestational age of 24 weeks or greater. So birth weight isn't considered as a criteria here. So we've adjusted our figures to make it comparable. So our figures are in the lower right-hand chart there. And so you can see that in the UK, they've been gradually having a decrease in their perinatal mortality rate. So that they've essentially, over the period up until 2020, they achieved a 20% reduction in perinatal mortality. The stillbirth rate, which is the main component of that, was reducing gradually. and to a lesser extent the early neonatal death rate. And that, obviously being the biggest country in terms of population, that was being driven primarily by the situation in England. And the added dashed curves there are antepartum stillbirths and intrapartum stillbirths, which we're not showing here in this for comparison purposes. So you can see that their rates are approximately 5 overall, approximately 3.5 for stillbirths, and about 1.6 to 2 for early neonatal deaths. We're quite similar, a little bit higher in terms of 6.2 for perinatal deaths in 2021, stillbirths 4.2, and early neonatal deaths 1.99. Some other differences are present as well. They exclude cases of termination of pregnancy, which are included in our graph. We have a high proportion relatively of deaths due to major congenital anomaly, which are included here, whereas this would be the case for about 10% of the deaths in the UK. And their increase, just from interest point of view, in 2021 was primarily due to deaths related to COVID. 12% of their stillbirths were babies who were born to mothers who were infected with COVID, and 4% of their early neonatal deaths, that was the case, which is much lower in Ireland. Okay, so one more comparison we just briefly look at is in the European context. Just kind of a different orientation to the chart here because of the number of countries, and apologies for the small text. But these are from a publication in the Lancet in 2022. Most of the years of data are coming from 2015, and we've included the 2015 Irish figures there in the first bar that's in dark, which would put us kind of above average, as it were. Here's the rate then for 2021, where we'd be more or less average, not much of a difference. So many of the countries are approximately 3.5 per 1,000 stillbirths. And then if we adjust for major congenital anomaly, we would have a below average rate of stillbirths. So a number of different factors involved, and of course we don't know the systems in each country either in terms of how comparable or good they are at ascertaining the cases. So then each year we have a series of funnel plots in our report. The most important from the point of view of benchmarking against the national rate is the funnel plot that corrects for major congenital anomaly deaths and also adjusts for in utero transfers, where the woman would have been transferred during her pregnancy to the care of primarily a larger hospital or tertiary centre. So you can see that the markers here that are labelled represent the 19 maternity units. They're ordered in terms of the number of births taking place in each of these units, which reduces as there's more and more births, there's less fluctuation expected. There's 95% confidence limits. So a unit outside of that, those dashed curves 2 years in a row would be considered an outlier, or outside of the full curves, the 99.8 limits would be considered an outlier if they were there in 1 year. So you can see that the red markers then are where the unit's rate would have been had they not transferred or had they not received transfers where the baby died. So that would have increased the rate in the smaller units as they transferred those babies out, those women out, and it would have resulted in a reduction in the rate in the larger hospitals. So ultimately, making those adjustments, no maternity unit was an outlier as defined by the National Office of Clinical Audit criteria. We then were asked by a member of our committee to look at the corrected rate separately for stillbirth and for early neonatal deaths, because again, there may be different factors at play. And we did that over a number of years because of the smaller numbers when you start splitting into the types of perinatal deaths. And a very similar picture occurs. Adjusting for major congenital anomaly and in utero transfers, there are no outliers over that 4-year period in relation to stillbirths, and a similar picture for early neonatal deaths. So again, lots of transfers occurring and making a big impact on the overall rate, as you can see. So I'll leave my part there now, and I'll hand over to my colleague, Indra.
Good morning, everyone. Yes, I'm here. So thank you, Paul. I'm gonna share my screen now. Can you see it?
Yeah, we have to stop sharing. Not yet, Indra. No, hold on a second.
Okay.
Do we stop sharing?
I did.
Okay. And now?
There we go. Perfect.
Yeah, perfect.
Okay. So I'm gonna very briefly. Sorry, 1 second. Whoop. Sorry for that. It just jumped. I'm going to very briefly show some of the key findings for the perinatal mortality report. As you can see in this first slide, advanced maternal age was associated with a higher risk of perinatal mortality in 2021. In fact, compared to mothers aged between 30 and 34 years, women aged 40 or more had a 1.8-fold increase in the rate of perinatal mortality in 2021. In relation to gestation at booking, 20% of mothers experiencing perinatal loss booked into hospital before 12 weeks gestation, and more than 70% attended for antenatal care between 12 and 19 weeks gestation. In 2021, the median gestational age at booking was 13 weeks. And as we can see in the figure, the proportion of women presenting for first antenatal visit at 20 weeks gestation or later was lower in 2021 compared to 2020, but higher than in 2019. As we can see in this table, women in the overweight category who experienced perinatal loss were overrepresented in comparison to the population of women who gave birth in 2021, with a perinatal mortality rate of 6.46, 6.5 per 1,000 for overweight women. In fact, overweight women had a 46 higher risk of perinatal mortality compared to women who gave birth in 2021 with a lean BMI. For the obese group, that increased risk was less evident in 2021 compared to recent years. When looking at parity, the first table shows that women who experienced perinatal loss in 2021 were broadly similar to the population of women who gave birth in 2021. But in the second table, we can see that a parity of 3 or more had a 28% higher risk of perinatal mortality compared to nulliparous women who gave birth in 2021. If we look at the mode of delivery, spontaneous vaginal cephalic delivery was the mode of delivery for approximately 70% of stillbirths and for 50% of the babies who die in the early neonatal period, which is similar to the proportion of women who had a vaginal birth in Ireland in 2021. When looking at multiple births, in line with findings published in previous perinatal mortality reports, multiple birth was associated with an increased risk of perinatal mortality. In fact, the rate for babies in multiple pregnancy was approximately 4.5 times higher than in single pregnancies. Again, when we are looking at low birth weight centiles, low birth weight percentile were associated with perinatal death in 2021, particularly stillbirth, with almost 48% of them in the category of less than 10, falling into the category of less than 10 centile. And finally, something to keep in mind is that when looking at the distribution of the birth weight centiles standardized by major congenital anomaly, cases of stillbirths and early neonatal death had lower birth weight centile when the cause of death was attributed to major congenital anomalies. And this is my section.
Very good. Thanks, Indra. Thank you very much.
No worries.
Just before we move on to the next one, Paul, I know you touched a little bit on the difficulty of doing international comparison, but can you just explain to people why it's hard to do international comparison?
Absolutely. So you'd have seen we mentioned about the different criteria, so gestational age and birth weight being combined as criteria or separately. And obviously, as you can imagine in different countries, then they may have different systems in place, and there may be less developed systems sometimes, so that the babies that are born very prematurely maybe not even recorded in some countries, so that the WHO recommends a kind of a higher threshold of one kg as the birth weight threshold, because there's an expectation that virtually all babies born at 1 kilogram or more will be recorded in the vast majority of countries, so that it should facilitate international comparisons. There is difficulty in relation then with termination and pregnancy, that sometimes countries include that in their figures, sometimes countries don't. And also then the issue of major congenital anomaly as to whether that's included or not included. And we know in Ireland that, you know, a high proportion of our deaths will be associated with congenital anomalies, which would not be the case elsewhere. So it's hard to get a like with like comparison.
And I suppose when we look at the data from other countries, we actually, if we look at the number of babies who have a reported congenital anomaly, they're actually often very low in comparison to ours. We even find that in the VON data as well. And that's probably because they're more likely to have been treated with with termination of pregnancy and therefore removed from the data. So it's really hard to get a good comparator. But by getting good data, we can very often make, as Paul did with the UK, because we had 24 weeks, we were able to at least do a comparison to the UK data, which was helpful. Okay. So we might just move on then to we're just going to share from here again now. Adele is going to take up the presentation.
Sorry, okay. Yeah, okay. Morning, everybody. I'm just going to talk about investigations into why baby died and the cause of death in 2021 and the trend out as well. So the overall autopsy rate in 2021 was 45%. That includes stillbirths and early neonatal deaths. As per previous years and also internationally comparison, autopsies continue to be higher in stillbirths. In 2021, it was just over half, 54%, compared to neonatal deaths, which is just 1/4 had an autopsy rate. The autopsy rate in 2021, you can see in the graph here on the right, was actually the lowest since 2018. The overall autopsy rate is the blue line there. Blue line is stillbirths. Overall perinatal deaths is the orange line, and the grey is early neonatal deaths. And we might discuss why that is likely later on. The placental histology, well, a high proportion of perinatal deaths have placental histology in Ireland. 95% of stillbirths and 87% of early neonatal deaths. In cytogenetic analysis, as Richard mentioned earlier, we have a high proportion of deaths due to major congenital anomaly, and over 91% of cases due to major congenital anomaly were diagnosed using the supportive diagnosis with a cytogenic analysis. Just comparing to the UK autopsy rate for stillbirths was 46% and early neonatal deaths 26%. So we do, while low, it does compare favourably. Nationally, the majority of perinatal deaths where an autopsy was not performed, and autopsy was offered at 78% of the cases. We did see some evidence of the impact of major congenital anomaly influencing the offer of autopsy. And you can see in the table below of stillbirths that did have a major congenital anomaly, 22.1% of them were not offered an autopsy where an autopsy wasn't performed, and versus 1.8%. And similarly with the neonatal deaths, 32.7% were not offered an autopsy when a major congenital anomaly was present, compared to 10.5%. There was a variation observed across the units in autopsy rates. You can see in the busy slide here on the right, the blue line represents the autopsy uptake. The green represents the autopsy not performed but offered. And the red is autopsy not performed and not offered. And just to note, in this slide, we haven't adjusted for early neonatal death versus stillbirths, or indeed the major congenital anomaly. But you can see there is variation across units that may reflect access to perinatal pathology services. However, some variation was seen across the larger maternity units, as you can see from the slide. Just to mention abnormal placental pathology, we in the NPEC have adopted a classification system in line with international consensus that was identified as meeting of pathology at the Amsterdam Convention. Overall, there's broad categories using terminology such as fetal vascular malperfusion, maternal vascular malperfusion, etc., as outlined in the table here. Interestingly enough, in the case of no abnormal placental histology associated, nearly under a third of stillbirths had no placental histology reported, and in neonatal deaths that was 75.9%. So what was the cause of death in stillbirths in 2021? There's a slight change in 2021 compared to previous years. Specific placental conditions accounted for 33% of stillbirths and 29% major congenital anomaly. Unexplained represented 15% of the deaths. However, it must be acknowledged that up to 60% of the unexplained deaths were pending post-mortem results, primarily coronal. And you can see of the major congenital, the specific placental conditions, fetal vascular malperfusion accounted for 23%, followed by maternal vascular malperfusion, 20%. Core pathology with distal disease also was a similar rate of 20.5%. Of deaths due to major congenital anomaly, chromosomal disorders accounted for just under half of these babies, 48.5%, multiple anomalies, 14.7%, and a similar amount for cardiac vascular system. Central nervous system, 7.4%, musculoskeletal system, 5.9%, and gastrointestinal, 4.4%. As Paul mentioned earlier, 2021 covered the year of the pandemic. In Ireland, we had a small amount, compared to our neighbours in the UK, we had thankfully a small impact on perinatal deaths. There was a severe third and fourth wave of the pandemic affected Ireland due to the Alpha B1.117 and the Delta variants. So in 2021, there were 9 stillbirths were due to the SARS-CoV-2 placentitis, and there was 1 early neonatal death. And using the NPEC classification system, these deaths were classified as due to other placental causes. Just to mention intrapartum death, they accounted for 5.9% of stillbirths in the Republic of Ireland, and the majority of which were due to a major congenital anomaly. Infection was the next most common cause, and then other associated obstetric factors and antepartum hemorrhage accounted in equal amounts for the remaining cases. And just in comparison to the UK and Northern Ireland, in Northern Ireland, 7% slightly higher rate of intrapartum death. In England, Scotland, and Wales, was a similar rate. Looking at the trend data for causes of stillbirths, as I mentioned earlier, there's a slight change in 2021. You can see the purple line there it represents a death due to specific placental conditions. You can see it was higher than the black line, which represents major congenital anomaly. However, looking over the last 6 years, if you combine the data over the 6 years, the range for major congenital anomaly and specific set conditions represented 30% each. There was a fluctuation in deaths due to unexplained and also in mechanical disorders. Mechanical being something like a cord, a nuchal cord. On the right there, you can see a table there, and just to highlight to you unexplained deaths. It comprises not only deaths with no known cause despite autopsy, but also includes cases where pending post-mortem or other investigations. And you can see of the 35 cases in 2021, 21 were pending post-mortems, and the majority of them were delayed coronal post-mortems, which, as you know, can take up to 2 years in getting results. So why did the cause of death in early neonatal deaths were 49% were due to major congenital anomaly in 2021, and 26% were due to respiratory disorders. Again, in unexplained cases, which represented 5.9 to 6% of cases, they were primarily awaiting coronal reports. So other major congenital anomaly, chromosomal disorders again accounted for almost 40% of congenital anomalies, followed by urinary tract anomalies. And deaths due to respiratory disorders, primarily due to severe pulmonary immaturity, accounting for just under half of the deaths, followed by surfactant deficiency. Again, just looking at the trend data in early neonatal deaths, it's been consistent, major congenital anomalies consistently being the main cause of death in early neonatal deaths, followed by a consistent rate of deaths due to respiratory disorder. And again, in 2021, 5 of the 7 cases unexplained were pending coroner's reports at time of writing. Cause of late neonatal deaths was similar. Major congenital anomaly again featured, followed by respiratory disorder and infection. Again, it's been consistently major congenital anomaly in late neonatal deaths, of which there were 40. The rate of deaths due to respiratory disorders has fluctuated over the years slightly, and infection, which is the green line there, as you can see from the chart on the right. Very briefly, these babies are not, small babies less than 500 grams and less than 24 weeks are not included in the perinatal mortality rate. However, we do capture data as these babies are registrable live births. Majority of them, 64%, delivered between 20 and 22 weeks, and a quarter delivered less than 20 weeks. All but 2 babies died within 24 hours, and the most common neonatal cause of death was pre-viability, 72%, followed by severe pulmonary immaturity, 15%, and just 1 in 5 cases were offered a autopsy. Following TOP, as Paul mentioned earlier, in 2021 they were included in the perinatal mortality rate. However, they were adjusted for in that the majority of babies, 8% of deaths meeting the criteria for PMR in the NPEC audit were following TOP, but they will not be included in PMR going forward. And the cause of death, apologies there. Sorry. Cause of death in TOPs, the majority of them, 25 or 26 cases, were due to major congenital anomaly, and 1 case was central infection, and the case of neonatal deaths all were due to major congenital anomaly. So these babies in the 2021 report would have been adjusted for in the perinatal mortality adjusted rate.
Very good. Maybe just before we'll go on for there, just to kind of add a little bit of colour to maybe some of that data. Do you have any kind of comments around, suggesting why there's an increase in autopsy not being offered? Because it was kind of 22% in 21. It was as low as kind of 16, 17% going back, and down like 2017, it was only about 10% of people not offered, or who didn't have or were not offered an autopsy. I think it's a change in practice that's happening, or is it just the years of the COVID pandemic? Or
this could be a change in practice. We have evidence that major congenital anomaly, or the presence of, does
could possibly impact on how parents are counselled re autopsy. Also, the high rate of deaths due to placental histology may impact on how parents are counselled re autopsy. During the early neonatal deaths, I think it's and I'm sure everybody listening this morning might say that parents, particularly when the majority of early neonatal deaths occur in premature babies, these babies are having tests done as they're cared for. So conditions like neurological conditions like IVH or HIE will be evident, and perhaps a discussion regarding the neonatal deaths impact and demise may influence whether an autopsy is offered or not. But certainly there is a dropping rate, and I don't know if something people would like to talk to that later, or if there's differences between units and just how the policy within units.
Because we know that there has been difficulty getting access to pathology in fairness in some units nationally, although that has been improving over the last couple of years. Okay. I suppose one of the other things just to ask a little bit about is that placental conditions being the primary cause, kind of increasing a little bit and maybe showing that it might become the most common. As it's, I know you showed it over the years, going up and down a little bit, but it is beginning to kind of edge up versus congenital anomaly. Any thoughts on why that might be?
I think that perhaps the placental histology, the area, the expertise in it is a high standard in Ireland. The UK do have high rates of placental histology, but we particularly have, and there is certainly at the moment a consensus of opinion on how to classify placental conditions. So perhaps a strong emphasis on placental histology. There's often, I suppose, a wonder when we discuss about cause of death, how to preempt it in the antenatal surveillance of fetal well-being. Unfortunately, histology can only occur after the placenta is delivered, but I suppose in focusing on fetal growth, because often they go hand in hand, intrauterine growth restriction and placental, small placental or poor placental function.
Very good. And just for going to the recommendations, I mean, I suppose one of the things about the COVID cases, two questions kind of really that come to mind. One is we had one early neonatal death and I think 8, was it 9 stillbirths? Yeah. Was there any? Do we have any evidence that the women were vaccinated or not? Or to memory, I don't think we had.
We didn't collect data on that data point, but interestingly enough, in our severe maternal morbidity audit, the women who were severely ill themselves, there was a low rate of stillbirth or perinatal loss amongst that cohort.
Yeah.
Whereas these babies that died, the women themselves were not severely ill. So it's kind of a conundrum really, but it seemed to either affect the baby or the mum.
Or the mum, yeah. So either the placenta or the mum, basically. Yeah. Okay. And I know we haven't got, but is there any evidence in the incoming data over 22 that has fallen off?
In 2022, to date, there has been no evidence of deaths due to placentitis.
COVID, yeah. So it looks like it was isolated.
Yes, to that
particularly to those
window
variants.
of it, yeah.
Yeah. Okay.
And interestingly enough, during the variants of that, one of them was what we used to call the UK variant. Yeah. And unfortunately, in the UK, they did have a huge impact. COVID had a huge impact on their maternity population.
Very good. Thanks very much, Edel. Thanks for that. So just to, one of the things that comes out of this data then is that we actually, find things that actually allow us to make recommendations that might actually impact on practice. And these are generally kind of proposed and tiered with our audit governance group nationally, and we normally look for an owner for the recommendation, and we discuss that with that owner before we actually put a title to it in a report. So just so that everybody knows we're not just putting people's names down. So I suppose one of the things that has come up again and again and continues to come up from the units is that is the difficulty they have in kind of doing this work and doing audit, literally because of time and the pressures of the front line. And so we continue to call for some approach to funding robust audit, and that this, in fact, might be better channeled through midwifery and obstetric management roles for clinical audits embedded in the job descriptions. That might be a way to actually have the greatest impact with any funding that comes. And that kind of, we're not the only place calling for this on our audits. Many NOCA audits are also calling for it, so that persists. In terms of one of the other areas that is, we get asked a lot of questions about, what is the impact of smoking? What is the impact of alcohol misuse and stuff like that in this data? And while we have some evidence towards it, one of our biggest problems is that we don't have background information for the, if you like, the whole population. So we have it for the women who have had a bad outcome in terms of perinatal mortality, but we don't really have good background information. We've got better in the last couple of years because we've managed to get information on quite sizable populations with respect to BMI, age, and things like that. But the things like smoking, alcohol, or other drug misuse and stuff like that, we don't have. So we continue to kind of look at that, and we're working on seeing could we actually impact on that ourselves and National Women and Infants Hospital Programme. This is a topic that came up in the early years of our audit and has come back up strongly again in the last couple of years. So while it's not directly from the data in the audit, it is a very clear line of communication that we're getting from the centres around the country, and this is that that there's a need for a communication policy to be developed regarding neonatal outcomes in babies whose care has been transferred post-delivery. So where a baby is transferred from a smaller unit to a tertiary maternity unit or to a paediatric unit from that hospital or from a major maternity hospital into a paediatric centre, there appears to be very poor communication coming back, and very often the staff looking after the mother in the hospital from the obstetric point of view have no information even when she turns up for her next pregnancy. So there may have been discharge letters done to the GP or whatever. They don't appear to be coming back into the. So we've made a recommendation around that, and the National Clinical Lead for Neonatology and NPEC are planning to take that on as to try and do something about it. We have called in the last couple of years just around the idea of an establishment of a confidential review for stillbirth and neonatal deaths, and this is to try and get, if you like, more in-depth data around certain cohorts. That might be multiple pregnancies, might be unexpected interpartum related deaths, and indeed stillbirths of normally formed babies. And again, that's kind of with the National Women and Infants and the Institute of Obstetrics and Gynecology. I will say that we have had some question put around this by some of our patient representatives, because they wonder what we're going to get better out of it, and that in other countries this doesn't seem to have impacted. And I think in fairness to them, they're probably not wrong, because very often we do in-depth reports, and indeed we've published on it from this unit through Dr. Anne Helps. And actually the biggest problem is that very often recommendations aren't enacted. So it's around the implementation of recommendations sometimes, rather than the form of report or assessment. I suppose one of the other things is that we know that there are some impacts from the data we can get from issues around general health, particularly weight, nutrition, lifestyle, even maternal age, and these are areas that should be addressed with patients. If we're following the HSE program of making every contact count. So we again make a recommendation that all healthcare professionals Very often, it's probably a little bit late when people turn up pregnant to obstetricians and midwives. But if we're impacting on at the end of care episode or pregnancy episode, we could impact by advising people around these issues. And therefore, that's something for all healthcare staff to take on. Standardized approach to the detection of antenatal death. So you saw when Indra presented the data there around growth. And again, this is a persistent recurring theme in the maternity, in this audit, is that there appears to be a very high rate of growth restriction in babies who are stillborn. Even normal babies where we've excluded babies with congenital anomalies. There is some evidence in the literature that can be addressed and can actually reduce the risk of perinatal mortality. And so we have called for a number of years now around the idea that this needs to be considered, and probably a multidisciplinary group need to look at approaches to it. It was also included in work done in the UK in the last couple of years, particularly in England with some of their attempts to respond to audit findings and reduce stillbirths particularly. So progress is that a working group has been established to address this, and the guideline is in development around this, coming from the Workstream 5 and the National Neonatal Encephalopathy Action Group. And hopefully that will begin to respond to this particular issue also. One of the things that we've put into this report is the idea of a care bundle, so that you actually begin to put a number of these recommendations into place with the view to trying to impact the perinatal mortality rate, and particularly this has been shown in other countries to impact the stillbirth rate. So this would include things like public health programs which focus on reducing smoking, weight management, and that relates to our recommendation around healthcare staff and the NPEC program. Developing care pathways, including staff education around risk assessment and surveillance for fetal growth restriction, using a national approach. Bring effective fetal monitoring during labour, with potential crossover effects on the reduction in neonatal brain injury, because this is something we're also seeing in the therapeutic hypothermia audit. And then developing standard approaches to the assessment of perinatal deaths, including or consulting with patients for reviews of their care. The learning points from these reviews could be communicated to all staff. And we also mentioned the confidential review again. So this is the idea that we all take on a package or a care bundle. And I suppose this was touched on in the invited commentary, which Tamara Escanel-Sanchez did this year, basically looking at exploring the complexity of stillbirth prevention, and it was insights from a study that she undertook her PhD around. There are national perinatal audits that are not that widespread. They're occurring in Ireland, they're occurring across the UK. Perinatal in Holland undertake them, and the Perinatal Society in New Zealand also undertake national audits. So the Embrace or NPEC with Embrace are the ones in the UK. New Zealand, it's the PMRC and Perinatal in Holland. So internationally, initiatives like the Europeristat. So Europeristat is a network of people who look and try and look at data across the whole of Europe, and reports from other bodies like UNICEF, WHO, United Nations, really focus on reducing stillbirth through audit and data analysis. So one of the big findings is that if you're doing audits and you're actually learning, you are actually going to have an impact on just by doing that alone. but by impacting into the recommendations, you're going to do even more. So here are some of the care bundles that other people have done, like the Scottish Patient and Safety Programme for Maternity and Children Quality Improvement. They were looking at assessing fetal well-being and fetal monitoring, offering women carbon monoxide monitoring, and referring them to smoking cessation services. In Australia, they've looked at smoking cessation, supported by monitoring fetal growth, promoting awareness of fetal movements, and advising on maternal sleep positions. If you look at the NHS Saving Babies Lives Care Bundle, they again looked at smoking, monitoring fetal growth, raising awareness of reduced fetal movements, effective fetal monitoring during labour, public education, carbon monoxide testing and education for healthcare professionals, and they've, in their new one of that, they've added in preterm birth. So you can see that, and in the UK and in Scotland, and indeed in New Zealand, through these programs, they've actually managed to have an impact that they've reduced their stillbirth rate by about 20%. So 20% for us would be dropping our stillbirth rate from, close to 4 to 3, or just, so it'd be quite impactful. So I suppose the potential for improvements in Ireland is around this area of the public health campaign to raise awareness about modifiable risk factors. And these are coming from Tamara's paper, which actually come from her PhD, which has looked at the literature across the world on this stuff. And so there is evidence for these. National standards for antenatal education in Ireland do not include any information regarding communication about the risks of stillbirth, nor education on how to support women with behaviour change for risk factors like smoking and stuff like that. So yet if we look at Australia, New Zealand, and the UK, all talk about fetal movements, and many of them talk about sleep positions and stuff like that, and we're not educating our women around those issues. So, and also one of the big findings from the research that Tamara undertook was that there are very poor information in the antenatal education and information sources, that actually women find it very hard to get good information, and even when they get into websites and other things looking for information, the actual quality of the information is very poor, and she and her collaborators actually did quite a bit of work around what was available. And then we have poor training of healthcare professionals in health promotion and lack of prioritization in antenatal care. So these are some of the things that potentially have come out of that research that could also impact on how we impact on perinatal mortality, and I suppose strongly on stillbirth. So I suppose just to finish off with the recommendations, then defining and auditing perinatal. So this goes back to the discussion we had with Paul earlier about the definitions, and a lot of Western countries have now, developed countries have now moved to fetal deaths greater than 22 weeks and greater than 400 grams. And so we've been suggesting that maybe we should be making that move as well. And we undertook the recommendation ourselves and said we'd bring a group together, which we did on October 11th this year, including the stakeholders like the CSO, Department of Health, GRO, HPO, etc. And there was a general broad agreement around this, and there is a piece of work going on at the moment to feed back to the GRO, because this legislation is changing. Anyhow, there are some changes coming to it. So this may actually happen, and we are grateful that actually a lot of units do actually provide us with information on the neonatal deaths. What we're missing is the stillbirths prior to 24 weeks, and we reckon it will probably have an impact, a very small impact overall on rates and that, but it would actually allow us to really compare internationally. And so just to talk then that we've had an engagement with the Coronary Society of Ireland to explore the timeliness of autopsy reports. That was done along with NPEC particularly, and NOCA. And we did a submission in 2021, which has recently been, which was acknowledged at the time and has recently led to further discussions with the Department of Justice, who now have an open consultation out around reform, coronary reform. And so we're updating that feedback, and if the Department of Justice are very open to commentary if anybody wishes to give feedback through the consultation. The website is there at the bottom. So that kind of brings us to an end of the formal kind of presentation. Just to remind you that registration and a call for abstracts is open for the NPEC study day, which is on Friday the 19th of January. It'll be at the Midlands Park Hotel, Portlaoise, and also online. And the topic of the day is from pre-pregnancy to postpartum, understanding maternal adverse outcomes. So more based around our maternal morbidity audit, but going much broader than that, and also looking at the reports that have come out from the maternal death inquiry in Ireland. So thank you very much. So we can probably bring down the sharing. Yeah, thanks. So I have a good few questions that have come in here. So the first one from Anne Helps. Were there any deaths related to neonatal encephalopathy? So some of our interpartum deaths were in there.
Yes. Overall, the early neonatal deaths, the neurological accounted for just 11% of deaths, but just 3 of them, which is a small amount, were HIE, 2 of which were over term and were related to interpartum events. 1 was pending coronal investigation and another was following a difficult delivery. So a small percentage. And yeah, we do capture them. And again, in the report, we look at interpartum related deaths. Normally, historically, interpartum death was the goalpost for judging care, but we feel that early neonatal death, babies dying in the early neonatal period, could also be due to interpartum events.
Yeah, so we'll catch those in a minute, yeah.
Yeah.
Very good, thanks. There's a question here from Anne, which is, what is the current advice on counting fetal movements? I think it's, I don't know that there is any formal advice on it. I mean, you still have people who talk about the, 10 counts and all the rest of it. But I think most people have moved towards just getting women to actually have a real feeling and understanding of their baby's movements, because babies vary an awful lot. And actually, if they feel that it's not in keeping with the pattern of movement and the timings of movements and stuff like that, that they would generally then get checked out. So I think that's from my understanding, and I don't think we don't have a new national guideline around that. Right?
No. I think again, she said just a deviation from the normal.
Yeah.
But it's good. Actually, Richard, on that point, I'd like to ask you a question. I noticed from your presentation that in the Southern Hemisphere, they talk about sleep pattern very much of women.
Yeah, so there's a good bit of research actually around sleep pattern, and particularly around sleep position is where most of the work is done, and a lot of the work was done in New Zealand, where they've actually assessed blood flow in the inferior vena cava, particularly. With respect to position, whether women are lying supine or on their sides, and they've shown some very significant impacts on blood flow. And I know that there are quite a few researchers in New Zealand who are very driven in a lot of their talks, and that they're actually talking about the need to really consider this. It is something that that we kind of advise here, but I don't know that we don't seem to have any formality around that advice. I think that would be where it is, but there is a research base to why people. I mean, there is the long-term epidemiological history of it, but also there's a scientific research base from radiology now to show that actually is impactful. Just a couple of comments that are on the screen, which we'll touch on, is Declan just talked about the reduction in autopsy rates in the NPEC reflect improved placental analysis coupled with improved antenatal assessment of abnormalities, and a 2-year wait for coronial reports is disgraceful. This not only affects your results and national audit, but directly affects the ability of clinicians to counsel parents. Perhaps NPEC need to take this up the coronial system. Well, we have, in fairness, and I mean, one of the things that's done in the UK, and in fact, I've been involved in a discussion with the Coroner Society about this some time back, is that in the UK, while it takes quite a long time for coronial results and the formal results not to come through, the UK situation actually is that they provide an interim report, which has guidance on it that it may not be the final report and all the rest of it. They provide an interim report, which is provided to the medical staff looking after the patient, the mother, or the couple, at least allows a discussion to happen. And if there's anything that should change in a future pregnancy, that can be discussed up front. We actually currently are sometimes meeting women back pregnant, and actually we haven't got any results. So that is a significant, and it is one of the issues that we've raised in the input we've given to the Department of Justice around the coronial system already. So thank you for that. There was, and the counting was the other one. Yeah, perfect. Okay. So don't think we have a question for Adele here. Were these? Oh yeah, these disrelating capillary. Yeah, you've answered that question. Yeah.
National Perinatal Corner suggestion there from the top of the chat.
Oh yes, so there's another comment about the coroners. Is a response to Declan that maybe it's time to advocate for 1 to 2 national perinatal coroners that have expertise on perinatal deaths and therefore standardise the process for families, hospitals across the country, which in turn would hopefully reduce these significant delays. I think it might be worth putting that in as a submission to the coronial, like the idea of some kind of a centralised function, and maybe even then specialists, even if there were specialist people who could assist other coroners in these cases, it would be very helpful. So I think that's a very helpful suggestion. Thanks, Anne. Yes, so I don't think we have any other questions. So we're coming up right up to on time. It's 10:59. So we'll probably close the webinar. Just remember our study day on the 19th of January. And thank you all very much for joining us this morning, for your interest and input and questions and comments.
Just to reiterate that the report will be up online today on our website this evening, and also infographics, and there's some supporting documentation that our colleague Tamara has done a great job on, so that's all available online.
And actually, just talking about that, if you haven't been on it, we have done a huge amount of work on our website. It's updated. It's a lot easier to maneuver and get around. And so if you haven't been in there, you could always wander in there today to see this report, and you'll see a lot of the other stuff. It includes a lot of the resources, connections and contacts to other places around any of our audits